hey, I've come off my birth control pill. I was on it for 15 years from age 15 to 30. Now I'm interested in becoming pregnant and I'm not sure if I'm ovulating. Now I'm starting to have these symptoms like increased acne, hair growth in some strange areas, and I've also gained a lot of weight. What might be going on? I've never had any lab workup, by the way.
How would someone know if they have PCOS?
Most of the time, you don't know. It's a very common condition. It's also on a continuum or spectrum, so some cases are very strong, some cases are very weak. Some are mostly androgen dominant, some are mostly insulin resistant, some are mostly genetic or other factors as well. And then you can be at any point on that XYZ plot that you might want to be at. One of the common occurrences or things that we hear, and myself being the patient, you being the provider, is hey, I've come off my birth control pill. I was on it for 15 years from age 15 to 30. Now I'm interested in becoming pregnant and I'm not sure if I'm ovulating. Now I'm starting to have these symptoms like increased acne, hair growth in some strange areas, and I've also gained a lot of weight. What might be going on? I've never had any lab workup, by the way.
Yeah, this is a fairly common plan, the plan that patients are put on. And at 15, if a girl goes to the doctor, hey, I'm having irregular periods, or my periods are painful, a lot of times you're put on an oral contraceptive, and then you have a decade where you really don't know, what's going on because you're not going through those hormonal shifts every month. So whenever you come off of that, you're going to have some changes in your hormone profile. Typically, you're going to have an increase in free testosterone and total testosterone, but particularly the free testosterone because your SHBG will come down coming off of an oral contraceptive. Mm-hmm. And then you will also, sometimes it takes a while to reestablish a normal cycle. There's a number of different factors that go into that. Mm-hmm. But if you are having irregular cycles or missing your cycles and you're not ovulating, that can be a clue that you may have PCOS. A lot of times mm-hmm. fertility is something that we've been trying for a while, and then when you elicit a history, I ask, do you have any hair growth in certain places, or have you noticed acne that's problematic? And if you have had any medical workup before, have you had any imaging of your ovaries that showed cysts? And that sort of gets into the Rotterdam criteria, which is very non-specific, because you just need 2 out of the 3 criteria, issues with ovulation, androgenic symptoms, and then the other would be actual seeing cysts on the ovaries. So looking at those 3 things, you just need 2 out of 3 to make that diagnosis. Mm-hmm. So for example, a woman who's using anabolic steroids could be diagnosed with PCOS because she's not ovulating and she's got facial hair or mm-hmm. hair in androgenic places. So it's really not a great criteria. So there's probably many people have been told they have PCOS and they don't, and many people with the PCOS phenotype who have been told they don't have PCOS.
Mm-hmm. Correct. In the diagnosis and workup for any pathology, it's important to, one, look at what common pathologies it might be, and then 2, rule out very rare but very severe disease states. For example, congenital adrenal hyperplasia as another pathology that could be masking as PCOS.
Yeah, there's a lot of overlapping symptoms with those 2 specifically. And then even other fertility issues, like if you're checking, have your thyroid ever been checked? Because that's another common cause of fertility problems, or a prolactin level. There's a pretty extensive history, physical and lab workup that needs to be done to kind of establish this diagnosis. Mm-hmm. But then once this diagnosis is established, we'll talk about treatment a little bit later on, but what does this mean for the patient's fertility? What does this mean for their ovulation? How do they know if ovulation is occurring? What are some of those things that they need to know about as far as the process of the underlying state or condition?
At very least, this individual should be doing pre-conception planning in adjunct with their partner, but really everybody should be doing that anyway. And at most, this individual might have very significant subfertility or even infertility and persistent anovulatory cycles. The degree of oligomenorrhea, which is usually defined as less than 9 periods a year or an interval of more than 35 days in between menstrual periods, That is not necessarily correlated with anovulation, but it can be. Some common methods to track, one is cervical mucus monitoring, which can be fairly difficult to learn, but a lot of places do teach it. You can do basal body temperatures, which again is fairly difficult to learn. You can also test progesterones in the luteal phase, so kind of at the end of the cycle. You can also test for an LH spike, often at home, because sometimes it's only spiked up for about 12 hours. And then you can also do things to assess persistence of fertility, including antral follicle counts, anti-Müllerian hormones, ratios of FSH to LH, even estradiol levels. So there's quite a few to assess to see should this individual be thinking about freezing eggs now if they don't plan for fertility in X number of years.
Yeah, because there is a window there, and earlier is better, but everybody's circumstances are different. And I think it's important to point out, if you're having these workups done looking at progesterone, estrogen, actually actively evaluating your fertility or your fertility window, best to be done off of contraceptives, because otherwise you're essentially going to be not having functioning or not fully functioning ovaries, not going to be ovulating, and this workup would not particularly yield much useful information.
Mm-hmm.